and talk again about now the other scenario of let's say the opposite scenario of we've talked about one-to-many, and now let's talk about a little bit many-to-one. So when we have several services under the provider, which reflects only in one code only. And I think there are two scenarios here. You've got the scenario whereby it's just the services are the same service, but written differently or provided differently, or you've got also a case whereby maybe possibly the CCHI billing system does not have a specific code that would reflect certain specificity that's there on the CCH that's on the provider, but it's not in the CCHI billing system. Let me start from you, Eileen, since you were talking about specificity. Have you came across examples of, like, you've seen many descriptions that went ahead into one code?
Oh, I'm sure we will have, but off the top of my head, I can't think of anything right at the minute. But it's usually when there is, because when we talk about specificity, sometimes the classification will list, a number of body sites, but then for the ones that are not listed, they'll group them into a not elsewhere classified sort of code. So it sort of bundles it up. So that in those sorts of examples where the classification isn't extensive, because obviously you can't you can't possibly classify everything. Sometimes that you will have certain medical services that will be bundled, and it's usually into, when we can't classify something, it moves into sort of an unspecified bucket, and that's where you'll quite often get many to one. But it's and that could also be used when often when we've tried to map some descriptions previously and there hasn't been the description of the body part used, or the body part, or for example, an abscess, a drainage of abscess, but a drainage of abscess from any part of the body should be separated out, but because it wasn't documented, it's gone into one code. So it's sort of that catch-all bucket, which isn't probably, that's where you're not getting your specificity. So that's probably what I can think of off the top of my head. There's probably more examples of those, and you will come across them during the process.
Thank you, Eileen. Noura, thoughts on this particular area? I think you've already also seen some examples as well.
Yes, we have seen some examples where the provider is having the same service mentioned several times. This service is covering one part of the body, and it almost have the same components. Therefore, the provider is mentioning it several times, but at the same time, we can with different pricing, but it will go under one code under the CCHIBS. For example, the drainage of pelvic abscess. You can see that all these services that are mentioned here are under the same part of the body, follows the same procedure. Therefore, we are taking it under one code, which is the drain of intra-body abscess hematomatous. In this case, the provider might have an impact if he is pricing each one of these services differently. Therefore, we recommend that the provider will have the price that will follow the minimum and the maximum cost for these services, and get the median, and accordingly start pricing these services. This also, I want to comment on few questions we are getting. It's very important that we have the whole process built together and in the right way. The process starts with me as a hospital having my internal codes, my current price list mapped to a new CCH-IBS correctly. This is the first important milestone, because the mapping itself, if it is not done properly, it will have an impact on me as a provider. The second thing is to put the prices properly against each one of these services. The pricing will change, whether we like it or not, the pricing will change. I can't have the same price for my services currently and map it to the SBS CCHI again and have the same prices. As we said, we have been giving all of these examples to show the impact of this change and how we need to accommodate this change in our price list. Then it will come to the doctors who are doing the documentation for these services. The way that the doctor is documenting my services will impact my revenue as a healthcare provider. If the documentation of my doctor is incomplete or is having the wide or the general description, it means that the coder will follow the general code and it will have a lower price than what it should be given to this claim in particular when I'm claiming my services to the insurance companies. I wanted to have this very clear for everyone because it really has an impact. We might sometimes, some of the providers might say that, okay, I have coders, I will code it, and then I will have my pricing done correctly. But if not, I'm not following also with the doctors, my pricing and my revenue will be impacted based on these documentation. So this example is one of many that will show us that the doctors, when they are using the documentation, if they are using general code, and it will lead to us mapping these to the general code at the end. The same what was Eileen was saying previously.
Okay, thank you so much, Noura. I think we have another example which talks about, since you're talking about the pricing and the impact on pricing, I think this is a good example of how the provider prescribes and how the CCHI reflects and the difference of prices. Sorry.
Exactly. For example, in this scenario, we have the suturing of cut wound. It just came like this from the provider with the price of 200 Saudi riyals. Now, when we are doing the mapping, we have different sizes, we have different additions to this suturing to be added. So if I will take the very general ones, we have small, medium, and large sizes of wound suturing that needs to be mapped to. So I will take this particular service and map it to 3 different codes, small, medium, and large. My current price is 200. If I'm looking to have a net or zero impact on my revenue, then I have to start, like, let's say, for example, with the small for 50 riyals, and go up to reach to the 100 riyals, where my average will stay at 200 riyals. So I will change the price. Instead of having only one code and one price for suturing the wound or a cut for 200 riyals, I will have the suturing of the wound divided into 3 categories based on the size of the wound, and I have to price it accordingly to reach to an average between these 3 codes, which is 200. We might have to map this code into more codes, which in this case, we are having another 3 codes. So one to many, we are mapping 1 code to 6 different codes, which is involving soft tissue. So we are having the same code, which is mapped to 6 codes, and each of these codes will have its own price, and we will have to change the pricing to match each one of those changes and each one of those codes. If we will go more specific, and if the provider is not mentioning this in their price list, for example, we have the repair of wound or suturing of wound for eyelid, for example. So each part of the body will have a special code for it, and we will have to have this code in our price list, and we'll have to have a price for it for us to be able to bill it to the insurance companies. I can't use the same code across all my services that is falling under this category, basically.
Yeah. Thank you. I think this is a great example. I personally use this example a lot since I am not a coder, and so I find this one is clear and easy to explain. So basically here we're no longer talking so the idea is somebody will go and take his 200 suturing of cut wound, will map it to 300260010, which is here is defined as small, put 200 on it and send it to the insurance company. What ideally should be done is he ignores the 200, go back, maybe if he doesn't want to ignore the 200, maybe go back to his current cases of suturing of cut wounds and see if he has enough a system that will allow him to look at his history. He will see if he has good documentation, whether the majority were small, medium, large, and then he can come up with where the 200 should fit, or he can recalculate the cost and basically go and say, okay, I am now going to use, instead of me using one code for 200, I'm going to use three codes, 300260010 or 20 or 30, and then I will put one for 50, one for 125, and one for 300, for example. And and I'm going to go back to the insurance company and talk to them, explain my logic behind why am I changing the pricing. Tell the insurance company, look, if somebody is coming at small or medium, I'm not going to longer charge you 200. Yes, I'm charging you 300 when it's large because it takes me more time. But at the end of the day, when I'm doing something smaller, I will charge you smaller, and this will balance the cost. Me working on the insurance side before I started working on Acumed, that logic would have worked with me if the data is done correctly, if the analysis is done correctly, I would accept that. And this brings me back to the discussion you and me have. Mapping is not the right way. I know we titled our webinar mapping and pricing, but actually it should be in reality a repricing taking into consideration your cost and making sure you have a zero impact on the insurance side, or at least if you have a higher impact, you are able to communicate with the insurance company and explain why. But again, I understand the complexity, and it's a good exercise to start at least with the mapping and then move on.
Yeah, actually, even if the providers now have not calculated their current costs, we really recommend them to go to calculate cost behind each and every procedure that they are having currently, because at the end of the day, if I'm charging the insurance companies 500 Saudi riyals while my cost is 700, it will have an impact on my revenue. It will have an impact on the way that I am going to give the quality of care at the end. So even if it's not done now when we are implementing, maybe next year, maybe within the next couple of years, we will have this study ready, and we can go back to the insurance companies and revisit our prices with them again.
I completely agree with you. I think the provider, I advise providers always, when you are doing mapping, it's very good exercise to look at your history and try to code your current cases and see how would they reflect after you do. It's a sanity check on your mapping exercise to see how are you performing. You have to do that. And I think it's also important to use the full spectrum of CCHI billing system. CCHI designed this for the particular reason and the clear reason of being able to get specificity and collect data from the market that they will utilize to manage the sector, basically, for the improvement of the healthcare system to everyone and for the transformation to value-based healthcare. So providers are encouraged to make use of the full spectrum rather than just, okay, I have one code, I found one code, and let me map this to that and ignore the rest. So actually use the whole spectrum. Try to, even if you are unable to reprice it now with the insurance companies, still ask your doctors to document and code those cases to the right specificity internally, because like you said, you will be able to collect data. Maybe not now, you don't have it, but in 6 months, year, 2 years, you will have the data you need to go back and build your cost properly and renegotiate with the insurance companies, either up or down, it doesn't matter. But renegotiate something that works for the insurance company and works for you and works for the patient. So before I move on, and on this particular point, I'd also like to have couple feedback on couple things from Mr. Abdullah. So first of all, Mr. Abdullah, a question that is coming from the audience, which is related to what if I have certain. Now we have seen most examples. We see that the CCHI billing system is more specific than the let's say what we have now as price list. But in cases where, for example, certain procedure did not have an equivalent in CCHI that is as specific, can the providers come back to CCHI and suggest a change? Can they provide feedback? We've got these questions with example in terms of I have certain procedures or certain services which I'm unable to find an equivalent code to it.
Thank you, Dr. Ayham. I believe in this particular time frame, especially we will launch the CCHI system. We expect for the first year that we will receive the feedback from the market to even that to add or to enhance the coding in the CCHI system, and that's expected. What we asking the market now, and every time that if you think that there is any such code that is not there in the CCHI system, please send it to us. We have a particular email for the kind of this request, which is the CCHI billing system at cchi.gov.sa. So we will review it. We have also a task force, clinical task force, who they also review the feedback from the market and approve whatever the code that they seems it's necessary to be there.
Okay, great. So I think everybody heard it. And to answer the question we received in terms of if I don't find the specific code, please refer back to CCHI and they will look and consider. Mr. Abdullah clearly is saying that the system in the first year is implementation and they are capable to change to suit the market needs. So this is, I think, great news for the market, Mr. Abdullah. I think the other point I want to talk to you about is also documentation and medical record. I'm sure you're hearing all this discussion. If you look at this example here, providers now bill 200 reals to suture a cut, and then we're asking them to move and break it down and use more codes to get more specificity, which is great. But then if we think about it, if the doctor, when he was doing the procedure, didn't mention small, medium, large, I'm taking this example on the screen, then again, the coder will have a problem of what he is going to code, and most probably he will have to go with the lowest one. So he will probably go with the small. I don't know. There has to be there are coding guidelines around this. So what are your thoughts around as a regulator around documentation, around medical records? What's your advice also to the sector and to the provider in this regard?
Also, Dr. Ayham, you know that CCHI they roll out NFIs, and NFIs now will capturing the financial services, but later on in this year, inshallah, they will also capturing the clinical services. So all the services that they should be captured in the medical record of the patient will be captured in NFIs clinical services. As you mentioned, the typo or the error that the coder or even the physician himself, when he just not reported exactly, that means that they will put themselves in position, maybe they will have less payment than they should be expected, because that there is a lot of codes that even for the same procedure, but as you said, the specificity of the code and the complexity, as much as you documented and clearly show it to the payer, then they will receive the correspondence payments for it. However, as in CCHI, we regularly recommend the market to do the documentation. And I think Eileen also previously mentioned that it will be part of the DRG. So when it comes to the DRG, and that within the grouping that group all the services that maybe will also affect your payment. So whenever that you will do the documentation, the more that precisely show that the insurance company that these kind of services have been rendered to the patient, and the insurance company, as we all know, that they will not have any thing to do with rejecting this kind of services, since it's clearly identified and documented.
Okay, this is very clear, and thank you for the answer.